Hello friends, so now we are going to learn about CVS radiology, that is basically about the heart, aorta, pulmonary artery and the peripheral vessels, Doppler as well. So what are the various modalities that we have for imaging of the heart? So for imaging of the heart, we have X-ray, the chest X-ray, the preliminary investigation, which helps in calculating the cardiothoracic ratio and which helps us in identifying cardiomegaly. So if the CT ratio is more than 0.5, then it is cardiomegaly. But in the AP view, we know that there is false cardiomegaly. So in that case, the CT ratio normal cutoff is taken as 0.6. Even in neonates, because we take a AP view supine X-ray, that is why the cutoff is 0.6. X-ray is also the investigation for the medical devices positioning, like the pacemaker leads, the various medical devices, the central line, all that position is on chest X-ray. Next we have is the CT scan, where we look for the calcium score, basically for the load of the atherosclerosis, and for that we use non-contrast CT, not a contrast CT. Why? Because contrast CT, the contrast is white, the calcium is white, so it will be difficult to differentiate. So non-contrast CT for the CT calcium score, which is called as Agatston score. Next, we have the ultrasound, which is echocardiography. Echo means sound. So, ultrasound is echocardiography, which is transthoracic or transesophageal. Transesophageal echocardiography is best for which chamber? The left atrium. Why? Because it is the posterior most chamber of the heart, which is close to the esophagus. So, esophagus ke aage we have the left atrium. Esophagus ke side mein we also have the aorta. So TEE is also done for aorta. It is the investigation of choice in aortic dissection, especially if the patient is unstable. Then we have MRI. Cardiac MRI is being used these days more often for ejection fraction, the left ventricular function. It is the most accurate investigation, and it can also help in MI. So if you have a patient who shows late subendocardial enhancement, that is suggestive of scar. The subendocardial is the location of the myocardial infarct. So late subendocardial enhancement is suggestive of myocardial infarct. We also have multiple nuclear scans, which we would be seeing in nuclear medicine as well. To give you a brief overview, for myocardial perfusion, the reversible ischemia, we do the thallium scan. For MI, hotspot is seen in pyrophosphate scan. Remember, pyre is fire is hot. And for viability, to look for the hibernating myocardium, PET is the best investigation, combining metabolism with perfusion. That is the best investigation. MOGA scan is the nuclear scan, which is done for LV function, but we said the most accurate is the cardiac MRI. Now coming to the heart borders, very important. The right heart border is predominantly formed by the right atrium. Remember, this is the right atrium. Right ventricle is here. It forms the diaphragmatic surface, not the right heart border. So we have right atrium, superior vena cava, inferior vena cava, which form the right heart border. And sometimes, especially in elderly patients, the ascending aorta also contributes. Now the next that we have is the left heart border is predominantly by the left ventricle, and then we have the left auricle. Remember, it's not the left atrium, it's the left auricle. Then we have the pulmonary artery, the aorta and the left subclavian artery. Now identifying the heart chambers on CT MRI, recently asked question. So here the anterior most chamber of the heart, which is behind the sternum, that is the right ventricle. And that is why that is the one which is injured in stab injury to the chest. The right ventricle is the one which gets injured. Now, if this is the right ventricle, this is the midline of the heart. So, to the left of our left-hand side are the right-sided chambers. We have the right atrium. Then, on our right-hand side are basically the left-sided chambers, the left ventricle and the left atrium. You can see that the chamber which is just in front of the vertebra, the posterior most, that is the left atrium. And left atrium ke baaju mein, here we will have the esophagus, and then this is the aorta. So we saw that TEE is good for LA and the aorta. What is this structure which is draining into the left atrium? This is going to be pulmonary vein, right? The pulmonary veins goes into the left atrium. This structure coming from the left ventricle is the aorta. Look at this one, the three major vessels in the mediastinum, and from right to left it is SAP. That is, first on the right is superior vena cava, then the aorta, and then the pulmonary artery. The AA tells you that this is the ascending aorta. So, ascending aorta, anterior mediastinum. Descending aorta, the aorta is like this. Ascending is aage, Descending is piche. So this is the descending aorta, which is to the left of the vertebra in the posterior mediastinum. Anterior to that, we have the esophagus. And look at this, we have the right bronchus and the left bronchus. So left bronchus in relation to the esophagus. What are these vessels here? So this one, right in the center, the black air containing is the trachea. To the left of the trachea, arching like this, is the arch of aorta. To the right of the aorta is the superior vena cava, SAP, right? So SVC and the aorta. These three vessels that you see here, now adjacent to the trachea, these are the three branches of the arch of aorta. From right to left, what are the branches of arch of aorta? BCS. Remember, Bachelor of Computer Science. So we have BCS, the brachiocephalic trunk, the left common carotid and the left subclavian artery. It's not the right side. In front of these, the two vessels that we have, these are the brachiocephalic veins, which will unite and form the superior vena cava. So the two brachiocephalic veins. So basically, these are the 5 vessels that we are seeing here. This is the 5 vessel section in the CT chest. Now going to the various signs in the chamber enlargements. So when it is RVH, where does the apex go? In RVH, the apex goes up and out. In LVH, the apex goes down and out. That is how we differentiate. Then we have left atrial enlargement, which is seen in mitral stenosis. We would see the signs of that. So what are the signs of left atrial enlargement? So when the left atrium enlarges, first, there is straightening of the left heart border. So the left heart border from concave, it becomes straight. Then the left atrium, it causes the elevation of the left bronchus. So the carinal angle increases, the splaying of the carina. The atrium comes to the right side. That gives the double density sign. So what do we see here? This one is the prosthetic mitral valve, a previously asked question. This chamber here is the left atrium, which is enlarged. Look at how it is causing the increase in the carinal angle. Never the carinal angle should be obtuse. When obtuse like this, it is abnormal. Right? And look at how it is coming to the right side. So along with the right atrium, it forms the double density or the double right heart border. Now this elevation of the left bronchus on the lateral chest X-ray, it gives this walking man sign. So what happens? The trachea, the bronchus, the left bronchus goes up. So that gives the walking man sign on the lateral chest X-ray. What Mogul sign does it give? The third Mogul sign. Why the third Mogul? The first one is the aorta, then the pulmonary artery, and then the left auricle or the left atrium, then the left ventricle. So this is forming the third Mogul, the elevation on the left side. And it is the left atrial enlargement which causes esophageal indentation. Because we saw that behind the left atrium we have the esophagus. So it will cause esophageal indentation, right? So esophageal, which wall is getting indented? It is the anterior wall. Okay, it is the anterior wall indentation. Versus what causes posterior indentation of the esophagus? What goes behind the esophagus is the ARSA, aberrant right subclavian artery, and that causes dysphagia, which is called as dysphagia lusoria. Okay, that is called as dysphagia lusoria. Now, going to the congenital heart diseases, the various appearances. So let's first see the mnemonics and then we would see the images. Now, first one, to begin with the mnemonic, not the congenital disease, but where do we get the egg in cup appearance? So when I'm trying to put the egg into the cup is constricting the egg, right? The egg is not able to go in, it is constricted. So egg in cup appearance is seen in constrictive pericarditis. Constrictive pericarditis. Now when I am transpositioning this egg to side, so transposition of great arteries is the egg on side. Now this egg on side, I have attached to a string, so it is also called as egg on string. Next, where do we get the boot shape heart? Imagine a boot which is falling. So that is falling boot, that is phallostetrology. Where do we get the snowman heart? From where does the snow fall? Snow comes from above, not from below. So remember supra, snow is supracardiac, TAPVC, total anomalous pulmonary venous connection. Where do we have the gooseneck appearance of the heart? Neck. Around the neck we use a cushion. So remember endocardial cushion defect. Where do we have the sitting duck appearance of the heart? Imagine a duck which is sitting on its trunk. So that is trunk, that is truncus arteriosus. Patent truncus arteriosus is the sitting duck heart. So let's have a look at the images here. This is the boot-shaped heart, which is because of the RVH. Again, a previously asked question gives the boot-shaped heart. Boot is also called as Sabo, Cor and Sabu. That is boot-shaped heart. Tetralogy of Fallot, RVH. And in tetralogy of Fallot, we have pulmonary oligemia because of pulmonary stenosis. Remember that. This is the egg which is on side or egg on string. The string represents the narrow superior mediastinum because of the position of the vessels and because of the thymic atrophy. So TGA, and in TGA, basically remember it has association with maternal diabetes mellitus. It is also called as globular heart. Globular heart. Snowman heart, like this, the figure of 8, supracardiac TAPVC. So look at this heart and look at the supracardiac, the abnormal channel which is formed, that gives the figure of 8 snowman heart or the cottage loaf heart. What do you see in PAPVC? PAPVC, partial anomalous, it is present on the right side, and you would see that abnormal vessel which is going into the IVC. So that gives the scimitar sign, that's a Turkish sword. So PAPVC, okay, it can also be called as hypogenetic lung syndrome, where the right lung can be hypoplastic, okay. Next one, where do we have the box-shaped heart? Box-shaped heart is Epstein's anomaly or tricuspid aprasia, which is seen with lithium intake. The teratogenic effect of lithium is Epstein's. What happens is the tricuspid valve goes down. So because the tricuspid valve goes down, the right atrium gets enlarged, and that right atrium enlargement gives the box-shaped heart. The part of the right ventricle is going into the right atrium, so there's atrialization of right ventricle. So you would see the right atrium enlargement, and you could actually see a heart which is very huge and occupying the entire thorax. And on ECG, because of the right atrial enlargement, the atrium enlargement gives the tall P waves. Those are called as Himalayan P waves. Where do we see the goose neck? Neck around the cushion, endocardial cushion defect associated with Downs. The goose neck is actually the LVOT, the left ventricle outflow tract is elongated. So the elongated LVOT gives the goose neck in the endocardial cushion defect. Where do you see the hilar dance on fluoroscopy? What is the hilar dance? So at the hilum, the predominant shadow that is formed is by the pulmonary artery. What else contributes there is the superior pulmonary vein and the lymphatics, right? So this pulmonary artery is dancing. There's a lot of pulsations which is happening, and that is in the case of ASD. So look at the pulmonary artery because of the increased flow in ASD. So what happens in ASD? From the left atrium to the right atrium, right ventricle, pulmonary artery, there is pulmonary plethora and it causes the hilar dance. So remember that in ASD, the left atrium is not enlarged. In ASD, the left atrium is not enlarged. Important clinical clue, there is wide fixed split of S2. Wide fixed S2 split is suggestive of ASD. Now, truncus arteriosus, we have already seen is the sitting duck appearance. Now coming to pericardial pathologies, that is pericardial effusion and constrictive pericarditis. Effusion means collection of water. So there would be cardiomegaly that we would see on the chest x-ray. And classically the pericardial effusion chronic wala gives that water bottle heart or the money bag heart. So you get this flask shaped appearance. There is narrowing above because that is where the pericardium is ending. So remember, effusion is water, so it gives water bottle heart. What will be the investigation of choice? Ultrasound, because fluid, ultrasound, echocardiography. On CT scan, this is the gray density of the water that you are seeing surrounding the heart. Calcific constrictive pericarditis, you can see this white calcification along the heart. So CD is the investigation of choice. Look at this calcification around the heart. What do you see in JVP in constrictive pericarditis? Remember the M pattern. M pattern tells you the X descent is present, the Y descent is present, but the Y is a prominent Y descent. So both are present. Versus in cardiac tamponade, you have absent Y descent in cardiac tamponade. On the lateral chest X-ray, pericardial effusion gives this Oreo cookie sign. So basically the pericardial effusion, this water in between the two layers of the fat, that gives the Oreo cookie sign. So water in between the two black fat, the water is the effusion, that gives the Oreo cookie sign. Congestive heart failure. So in congestive heart failure, it is the left heart failure which will cause the back pressure to the lungs and cause pulmonary congestion. The right heart failure will cause the back pressure to the systemic veins and it will cause pedal edema and hepatomegaly. So the stages of congestive heart failure depending on the pulmonary capillary wedge pressure. If it is more than 12, it is elevated. So stage 1, 12 to 18 mm. What happens first? The back pressure from the left ventricle, left atrium going to the pulmonary veins, not the pulmonary artery. So the first is the pulmonary venous hypertension, which manifests on chest X-ray as cephalization of the blood flow. So the upper lobe vessels become prominent because of the back pressure. That gives that stag antler sign, the prominent vessels, or the hands up sign, or the mustache sign. Right? These are the various signs. Next, from the pulmonary veins, the fluid going into the interstitium. So we have interstitial edema, the stage 2, 18 to 25. This interstitial edema on the chest X-ray, it presents as the curly B lines. B means these are present at the base, the short horizontal lines. And on CT, this presents as smooth interlobular septal thickening because of the fluid in the interstitium. Stage 3, more than 25, the fluid now going into the alveoli. So that is pulmonary alveolar edema, which gives the confluent opacities. Central perihilar location, that gives the bat wing appearance. The bilateral symmetrical perihilar opacities, the bat wing appearance. And the fluid can go into the pleural space as well. And there is pleural effusion. Okay, there is pleural effusion. So let's have a look at the image here. What are we seeing here? Look at these prominent vessels in the upper lobes. That is the cephalization that is happening. Then we have the pleural effusion as well, which is there. Look at the perihilar haze, better seen here. The bat wing appearance of pulmonary edema. We have this curly B lines, the short lines at the base. Where are the curly A lines? Where are the curly A lines? They are present at the hilum. Curly A lines would be at the hilum. B lines would be at the base. Okay. And there would be cardiomegaly because the heart is failing. Now, what is the difference between cardiogenic and non-cardiogenic pulmonary edema? So, non-cardiogenic pulmonary edema is basically ARDS. It could be multiple causes like pulmonary infection, sepsis, trauma, pancreatitis. The patient presents with acute breathlessness, right? So, in cardiogenic, because it is the heart cause, there will be cardiomegaly. ARDS, no cardiomegaly. Pleural effusion, all the fluid wala component will be in cardiogenic, not in ARDS. Central perihilar opacities are in cardiogenic, not in ARDS. In ARDS, the opacities are more in the peripheral location. So remember that the fluid wala part is seen in the cardiogenic, not in the ARDS. Now going to the pulmonary artery. We saw about the heart, the various pathologies. Now talking about pulmonary artery, the pulmonary arterial hypertension. So pulmonary artery, we said that it is seen at the hilum. So what happens with the hypertension? The pulmonary artery gets enlarged. So there would be enlarged or dilated pulmonary artery. How do we define that? When the right descending pulmonary artery is more than 16 mm in males and more than 15 mm in females. And this is called as the jug handle appearance. The enlarged artery gives that jug handle appearance. It can be the central pulmonary artery also that can be prominent, which is seen below the aorta. Right, so the pulmonary artery gets convex, it gets dilated. So the prominent central pulmonary artery, which is called as Fleischner's sign, we would see in pulmonary embolism as well. The peripheral vessels, they go into constriction. So we don't see the peripheral vascularity well. That is called as pruned tree appearance. So peripheral hypovascularity, the peripheral branches are cut off, the pruned tree appearance, very important. Because of pulmonary artery hypertension, the back pressure, the RVH happens. So there is RVH, which on a chest X-ray will be seen as retrosternal obliteration because the right ventricle is present behind the sternum. So when it enlarges, it gives the retrosternal space obliteration. On the CT scan, SAP, the three vessels here, we see that pulmonary artery is more enlarged as compared to aorta. Normally, it should be other way around because aorta ka pressure is more than pulmonary artery. So when the pulmonary artery ascending aorta ratio is more than 1, it is suggestive of pulmonary arterial hypertension, right? Coming to pulmonary embolism, what are the clinical features? The predisposing feature is the DVT, the deep venous thrombus, then it goes to the right side of the heart to pulmonary artery. So DVT leads to pulmonary embolism. What leads to DVT is the immobilization, right? Prolonged immobilization, post-surgery, prolonged journey. And now the patient presents with acute chest pain and the shortness of breath. We suspect pulmonary embolism. So the screening investigation for pulmonary embolism is D-dimer. Right, that's a blood test. That means what is a screening investigation? It's a sensitive investigation. So D-dimer positive means that there's a chance of pulmonary embolism. D-dimer negative means there's no chance of pulmonary embolism. So if the D-dimer is positive, then we go to investigation of choice, which is CT pulmonary angio or CECT. So when we have a high likelihood of pulmonary embolism based on this criteria, which is the modified Wells criteria, or when the D-dimer is positive, then we go ahead and do CTPA to look for the site of pulmonary embolism. What is a gold standard investigation? For vascular pathologies, the gold standard is the invasive angiography, that is pulmonary arteriography, that is catheter angiography. Put the catheter and see for the embolism. So what do you see here in the images? Look at the SAP, the three structures. Look at the pulmonary artery dividing into right and left. So there is a filling defect occupying this pulmonary artery. So this is actually a saddle embolus, which is involving the main artery and the right and the left as well. So embolism on a contrast CT is indicated by filling defect of the contrast. It's a contrast filling defect that we would see. Now, what are the chest X-ray signs of pulmonary embolism? So we have the various signs, which are the Pala sign, the Hampton's hump, the Westermarck sign, and the Fleischner sign. So what is the Pala sign? PAL is the pulmonary artery large. Which pulmonary artery large? The RDPA. So it's the right descending pulmonary artery which is large. Hampton's hump. Hump is the infarct. So we see this wedge shape opacity which represents the infarct, that is the Hampton's hump. Hampton's line was benign gastric ulcer. Westermarck is the vascular mark. So with pulmonary embolism, the blood supply decreases, the vascular marking go down. So Westermarck is like vascular mark decreased. So that is focal oligemia. So that particular area will show less markings. That means it will appear more black, not more white. It will appear more black because of decreased markings. Then we have the Fleischner sign, which is the central artery which is large. So below the aorta, the pulmonary artery is prominent. That is where we look for the central pulmonary artery, right below the aorta. Now going to coarctation of aorta. Coarctation means the narrowing. The most common site for coarctation, that is the postductal, that is after the ductus arteriosus. So it is the lower limb blood supply which is decreased. So the patient presents with intermittent claudication. Renal artery blood perfusion is decreased. The kidney, so what happens is there is hypertension. To compensate for that, there can be headache, there can be epistaxis. The history also gives you the history of radiofemoral delay because the femoral pulse is delayed as compared to radial because of the decreased blood supply and the slow blood supply. Coarctation of aorta, also remember the association with Turner syndrome. Now what do you see radiologically is the figure of 3 sign. It is because of the narrowing. So the narrowing gives this figure of 3 appearance in coarctation. What else do we see is on the barium swallow. It is the reverse figure of 3. So figure of 3 on chest X-ray, reverse figure of 3 on barium swallow. What rib notching do we see? That is the inferior rib notching. Why? Because when there's coarctation, so to compensate for the decreased blood supply, the blood finds a bypass route through the collaterals. So the intercostal artery is getting prominent, forming the collaterals. So these prominent collaterals, they pulsate. Where are the blood vessels present? Along the lower border of the ribs. So when they pulsate, they cause the erosion of the inferior rib. So inferior rib notching is what we would see, not the superior rib notching. So basically any neurovascular cause like neurofibroma, VT shunt, that would cause inferior rib notching. Superior rib notching will be the muscular causes. Muscle attachment there, so connective tissue disorders, polio, rickets will cause superior rib notching. Right? So look at this inferior rib notching, which is also called as the Riesler's sign. Okay, this is also called as Riesler's sign. Now coming to aortic dissection. Aortic dissection causes acute chest pain, tearing sort of chest pain going to the back. The most important risk factor is hypertension. The high blood pressure tears the intima, that creates a true lumen and a false lumen. Right? So that is dissection. The clinical history tells you the history of unequal blood pressure in the upper limb because one of the upper limb vessel can be involved by the dissection. The classification that we use for aortic dissection is the DeBakey's and the Stanford classification. So we have Stanford A. A for AA, ascending aorta involved. B for below the ascending aorta. Okay. So when the ascending aorta is involved, it is Stanford A. When it is not involved, it is Stanford B. In DeBakey's, start with the most severe, ascending plus descending both, that is DeBakey 1. Only ascending is DeBakey 2 and only descending is DeBakey 3. Right. Now, what syndrome is this aortic dissection associated with? Remember an important association with Marfan's. What is going to be the investigation of choice? If the patient is stable, we can get the patient to CT scan and do CT angio. If the patient is unstable, we have to do a bedside investigation ultrasound, that is TEE, transesophageal echocardiogram. If the question is what is the most accurate investigation to look for the intimal tear, the length of it, then it is MRI. But we don't do it in acute condition because it takes a long time. So look at this image. This is SAP, the three vessels here. The ascending aorta is dilated and there is this intimal flap dividing the aorta into two, aortic dissection. The larger one is the false lumen. You have the true lumen. There is the beak sign, cobweb sign, which is seen in false lumen. It is also involving the descending aorta. So if I ask the DeBakey classification, this is going to be DeBakey 1, ascending plus descending. This is going to be Stanford A because the ascending aorta is involved. So Stanford A for acute condition, it needs surgical management. B for beta blocker, can be used, conservative management, if the patient is stable and there are no complications. What is this? This is the flap involving the aortic arch. So dissection of aortic arch here. Coming to aortic aneurysm. Aneurysm means the dilatation of the aorta. Most important risk factor is atherosclerosis that leads to weakening. So what are the cutoffs for the aortic diameter? Ascending, descending, abdominal is more than 5 centimeters, 4 centimeters and 3 centimeters. That is a cutoff. Now look at this abdominal aorta which is dilated. This is abdominal aortic aneurysm, which clinically will be given as a pulsatile mass, right? Then this is the aneurysm here. Look at this draped aorta sign, which is suggestive of impending rupture. So when you see the aortic aneurysm going till the vertebra, touching the vertebra, surrounding the vertebra, that is a draped aorta sign, it is suggestive of impending rupture and it needs surgical intervention or EVAR. The endovascular aortic aneurysm repair is what it needs. For carotid atherosclerosis, what investigation do we do? Carotid Doppler. Carotid Doppler is done for carotid atherosclerosis. Pseudoaneurysm, which can be seen because of trauma, arterial catheterization. Again, it presents as a pulsatile mass, right? So what do you see on Doppler in that case is yin-yang sign. What is a yin-yang? This symbol which has two opposite colors, white and black. Similarly, on Doppler, you have two opposite colors, red and blue. The red and blue indicate the direction. So two opposite directions. So in pseudoaneurysm, what you see is the blood coming in the vessel, going into the pseudoaneurysm in this direction, then in the reverse direction. So there are two opposite directions. So it gives the yin-yang sign. Okay, it gives the yin-yang sign. What do we have the next one? Coming to peripheral vessels, the arteries and the veins. The peripheral artery gives the triphasic waveform, right? The limb arteries, because of the high resistance, Vein give monophasic waveform. Normal vein, patent vein has respiratory phasicity. If the respiratory phasicity is gone, then that suggests that there is a proximal venous thrombosis. So for DVT will present as calf pain. What sign is positive clinically? The Homan sign is positive. There's calf pain. We will do Doppler or ultrasound, and what we will see is the vein. If we try to compress, it will not be compressible. Normal vein will get compressed. A vein distended with thrombus, because of the thrombus, will not be compressible. So non-compressible vein. We had seen the same concept in acute appendicitis, non-compressible appendix, acute appendicitis, right? Now, when you have peripheral vascular disease and arterial stenosis, the patient will present again with claudication because of decreased blood supply. There can be ulcer and there can be gangrenous changes. What is the first investigation that we would do? Doppler or duplex, right? That's basically ultrasound. And what happens with chronic stenosis? The body forms the collaterals, and these collaterals now are low resistance vessels, and they will give the monophasic waveform. So remember that normal extremity artery should give a triphasic waveform like this. If just an image like this is asked, which has been asked in the recent exam, this is the image of Doppler, right? Which is showing the waveform where you have this triphasic waveform is what we are seeing here. This is the image of Doppler. Now, another question asked is, where do you see the Mickey Mouse sign? The saphenofemoral junction shows the Mickey Mouse sign, where you have the femoral vein forming the face, and you have the adjacent femoral artery and the great saphenous vein adjacent to that forming the ears. So remember that at saphenofemoral junction we have the Mickey Mouse sign. Where else do we have Mickey Mouse sign? At the porta, where you have the portal vein and the common bile duct and the hepatic artery, which give this Mickey Mouse sign. So remember, there also we see the Mickey Mouse sign, right? Now coming to pacemaker. Now pacemaker leads position we can see on chest x-ray. That is the investigation for medical devices positioning. What are the types of pacemaker? It can be single chamber, dual chamber or biventricular. When I say it's single chamber, the lead goes into the right ventricle. Dual chamber, it is the right atrium and the right ventricle. Biventricular means it has the one going into the coronary sinus, the left ventricle as well. So look at this one, the biventricular pacemaker, where you see one, the right atrial lead, the right ventricular lead, right? The one going here is the right ventricle, and then you have the one going like this is the left ventricle coronary sinus lead. Dual lead pacemaker. Dual lead means one going into right atrium and one going like this. This is the right ventricular lead. A previously asked question in the FMGE exam, right? So you have the right atrium going upwards and you have the right ventricle. And how do you differentiate the pacemaker from the defibrillator? Now, ICD will have this high voltage coil because we want to give the shock. Whenever there's arrhythmia, the ICD is put for giving the shock and restoring the sinus rhythm. So to give that shock, we need those insulation coils which will be seen along the leads, right? So these high voltage coils, the insulation coils will be seen in ICD. They are not seen in pacemaker. So remember, the lead which is going like this downwards, that is right ventricular lead. Okay. So now we are going to learn about the GIT and the hepatobiliary and pancreatic radiology, focusing on the must know and the frequently asked images. All of these are like must know for the exam. So first, let's quickly identify the investigations here. The GI contrast studies that is done by giving barium. So the first one here where we see the esophagus containing the white barium, that is barium swallow. And as the term says, swallow is for esophagus and the hypopharynx. So you can see in the barium swallow, the normal indentations, the normal constrictions by the arch of aorta, the bronchus and the left atrium. It is the left bronchus which does the constriction. Next one we have is the barium meal. Now the meal goes into the stomach. So barium meal is for stomach. And this is where we see the stomach in the barium meal. Now when we follow this barium meal ahead into the small intestine, then it is barium meal follow through. Following it up till the IC junction, appendix also is visualized here. So when you see the stomach, along with the small bowel loops, complete small bowel loops, then it is barium meal follow through. And here you can see the bowel loops in the left side of the abdomen which have the feathery appearance, and these are jejunal loops. Okay, these are jejunal loops. And the ones in the pelvis which are featureless, which are characterless, those are the loops of the ileum. So ileum is featureless, jejunum is feathery. The next that we have is here the barium is through the transrectal route. So this is barium enema, which is for the large intestine colon. And this barium enema particularly that you see, this is the double contrast, because you see the white barium also and you see the black air also. So we can do double contrast barium studies which help us in better delineation of the mucosal pathologies. Okay, it helps us in better delineation of the mucosal pathologies. Now, what is enteroclysis? Entero, as the term says, entero means it is for small intestine, and in enteroclysis is like the small bowel enema. It is like small bowel enema. So what do we do is, instead of giving the barium orally, we put a tube, a nasojejunal tube. You can see the tube here. So once the tube is put, then we put the contrast, and here basically it helps in early and better opacification of the small intestine and the small intestine mucosa. Now for small intestine mucosa, the investigation that we prefer is the CT or the MR enterography. Okay, CT or MR enterography is what is done for the small intestinal mucosal pathologies, like to look for the activity of Crohn's, and that is done by giving mannitol. That's a neutral contrast. It holds the water, distends the bowel. So that's a neutral contrast, mannitol. Now, in the barium meal follow through, like this investigation also is BMFT. But what do you see here? That the feathery appearing jejunal loops are not on the left side but on the right side. And this is indicative of malrotation. Right, this is suggestive of malrotation. So when the DJ flexure, the duodenojejunal flexure does not cross to the left side, then it is suggestive of malrotation, because you see the cecum on the right side. So that is malrotation. Right. So this malrotation predisposes to volvulus, the mid-gut volvulus. And what do we see in mid-gut volvulus is this appearance of the duodenum, which is called as corkscrew duodenum. Okay, so what do we see is the corkscrew duodenum appearance. When we do CT or Doppler, what do we see is the volvulus has a twisting of the vascular loop. So that twist and the twist on the Doppler, that gives the whirlpool sign, right? So the whirlpool sign is the twisting that is seen. So the best study to look for the malrotation is basically the upper GI contrast studies, that is the barium studies, that will show the jejunal loops on the right side. Now, what is this X-ray here? This is an inverted X-ray. So this is an invertogram. Invertogram, as the term says, it is done by inverting the baby. And this is done for rectal atresia, the anorectal malformation. And what do we do is we invert the baby, we put the coin at the area of the anal opening. So this is done when the anal opening is absent, right? So to look for whether it's a low or a high ARM, the anorectal malformation. So we invert the baby, the air comes towards the anus when we invert the baby. If there is atresia, the air will not be able to reach till the anal opening, which is marked by this coin. So this area where you see the absence of air, that suggests the atretic segment. In the rest of the bowel loops, you can see the black air. Now we don't do this. Now the investigation of choice for anorectal malformation is MRI. Right, so for majority of the perineal pathologies, now we do MRI. Now the next investigation that we have is the endoscopic ultrasound. Now, endoscopic ultrasound basically is done for T-staging of the tumors. It helps in better delineation of the depth of the tumor. So, endoscopic ultrasound. Next, what investigation is this? This one is virtual colonoscopy or colonography, which is done in CT. Here we don't put an endoscope, it's just a CT scan, right? And it helps in the delineation of the mucosal pathologies like polyp that we see here. So this is virtual colonoscopy, which can be done in CT. Now coming to the pathologies here, most important in the abdomen, pneumoperitoneum, which is asked almost every time in the exam. So pneumo means air, peritoneum means in the peritoneal cavity. What is the common cause of pneumoperitoneum? It's basically perforation. A hollow viscous perforation is the common cause, right? And that's the reason that here barium would be contraindicated. Any case of perforation, barium is contraindicated. So if I ask you what is going to be the best investigation for pneumoperitoneum, the best would be the CT scan, because for air containing pathologies, it is CT. CT with oral contrast. And what is the oral contrast that we give here? The oral contrast that we give here is the iodinated contrast. CT with oral and IV contrast to look for the mucosal enhancement also. What is the best X-ray view? The best X-ray view is the chest X-ray erect. Okay, chest X-ray erect is the best X-ray view. And if the patient is not able to stand erect, then in that case, we can do left lateral decubitus, abdominal left lateral decubitus with horizontal beam of X-ray. Remember, always with decubitus, it is a horizontal beam of X-ray. It's not a vertical beam of X-ray. Why the left lateral decubitus? So that the air comes to the right side and the liver gives a good contrast to the black air. Right. So now let's have a look at the images here. The first image that you see here, very, very important. This is the free air under diaphragm. So the intestine perforating and the air coming out. So you would see it below the diaphragm. In the CT scan, this is the free air which we are seeing. There are no bowel markings there. Right. This is the left lateral decubitus. The left side is down. You can see the black air which is going above the liver. So left lateral decubitus. The other signs that we have, very, very important one is the football sign. So in a supine X-ray of pneumoperitoneum, when the patient has massive pneumoperitoneum, the air accumulates like a football. So that is the football sign. Then we have the Wriggler sign. What is the Wriggler sign? So in pneumoperitoneum, air inside the bowel, air outside the bowel, that gives a very good delineation to the bowel wall. So that is the Wriggler sign where the bowel wall is seen very clearly. So look at this. This is the bowel wall which is seen so clear on X-ray. Normally it is not seen so clearly. Cupola sign is a collection of this air beneath the central part of the diaphragm. And then we have the various ligament sign. The air delineating the ligaments like the falciform ligament sign. Here you have the air delineating the umbilical ligament. So that gives the inverted V sign. Okay, inverted V sign. And then we have the air accumulating in between the bowel loops like a triangle. So like you see here, the triangular accumulation of air in between the bowel loops, that is called as telltale triangle sign. Okay, that is called as telltale triangle sign. One more sign that we have in pneumoperitoneum, also remember the Doge cap sign, which is the air in the Morrison's pouch. So like the cap, we have the accumulation of air in the Morrison's pouch, that is called as Doge cap sign. Now going to the next one, pseudopneumoperitoneum. One of the causes is Chilaiditides. What is Chilaiditides? So what do you see in this radiograph is, there looks like there is air under diaphragm, but here this is not the free air. Why? Because we see the hausturations here. So this basically is the bowel loop, the colonic loop in between the diaphragm and the liver. So this is basically colonic interposition. This is Chilaiditides, which looks like pneumoperitoneum. So this is pseudopneumoperitoneum. Now coming to the esophageal pathologies. First one, very important, this diverticulum in the upper esophagus, which is directed posteriorly towards the vertebra. That is Zenker's diverticulum. So what is the classical clinical features in Zenker's diverticulum? The triad of an elderly person presenting with dysphagia. It's an esophageal pathology. Halitosis because of the food accumulated in the diverticulum, and regurgitation. This is the classical triad, the dysphagia, halitosis and regurgitation. And Zenker's diverticulum is a diverticulum in the upper esophagus, right? Upper esophagus between the thyropharyngeus and cricopharyngeus part of the inferior constrictor muscle. It's a false diverticulum, pulsion diverticulum, posterior diverticulum. What surgery do we do for Zenker's? It is Dolman's procedure. Okay, it is Dolman's procedure which is done for Zenker's. What is the best investigation? The best investigation would be barium swallow, to look at the barium going into the diverticulum. Next we have achalasia. So what are you seeing in achalasia cardia is this massively dilated esophagus, because the lower esophageal sphincter is contracted, and that gives the bird beak sign. The contracted lower esophageal sphincter gives the bird beak sign, achalasia cardia. What is the gold standard investigation? The gold standard investigation is manometry. Manometry is the gold standard investigation. Next one, CA esophagus. Rather, CA esophagus has irregular narrowing. Malignancy has irregular narrowing. CA esophagus is most common in the mid-third. Clinically, if I have to differentiate achalasia from carcinoma, in carcinoma, the dysphagia is to solids as well. While in achalasia, the dysphagia is for liquids more than solids. Why? Because the solid with its weight, it will try to open the lower esophageal sphincter. Here in carcinoma esophagus, it is mechanical obstruction. So even a solid will not be able to open it up. So here there is dysphagia to solid as well. And we would see the irregular narrowing with this shoulder-like appearance. Okay, there would be this shoulder-like appearance. This is called as shouldering. Similar thing in cancer colon. This is called as apple core appearance. Next, what are we seeing in the next image is this multiple contractions in the esophagus. This is multiple contractions, diffuse esophageal spasm. What is this appearance called as? This is the corkscrew appearance, which is seen in diffuse esophageal spasm. Where did we see corkscrew duodenum? Corkscrew duodenum is volvulus predisposed by malrotation. Now, esophageal webs and rings. Look at this esophagus here where you see the prominent transverse folds in the esophagus. This is called as feline esophagus because cat ka esophagus is like this and it is seen with reflux and eosinophilic esophagitis. For reflux, we do 24-hour pH monitoring. Remember, pH is basically for acid-alkali. So, the acid reflux, we do the pH monitoring. If you have a patient with this atrophic glossitis, iron deficiency anemia, and this in the esophagus, that is a web, right? This mucosal indentation sort of thing that we are seeing, the esophageal web, it's a case of Plummer-Vinson syndrome. It's a case of Plummer-Vinson syndrome which predisposes to squamous cell carcinoma, while Barrett's esophagus says adenocarcinoma of the esophagus. Next one, what is Schatzki's ring? Schatzki's ring is present at the gastroesophageal junction. It is associated with hiatal hernia. It is basically a B ring which has become symptomatic now. That is the Schatzki's ring. So this is the hiatal hernia that we are seeing, the stomach which has come up, and this B ring is now becoming symptomatic, which is called as Schatzki's ring. A ring is above, B ring is below. So remember that A ring is present more proximal, B ring is at the GE junction. So for hiatus hernia, what do you see with hiatus hernia? Now hiatus hernia will be the stomach going up and we would see a retrocardiac opacity. So look at this chest radiograph. What are we seeing here is there is a opacity here which is showing the air fluid level. You see the lateral chest x-ray. Behind the heart there is air fluid level, retrocardiac. The best investigation is CT which is showing the heart and behind that is this air fluid level. This is the hiatus hernia. So the best investigation for hiatus hernia is CT with oral contrast and classically it would show retrocardiac opacity with air fluid level. Now coming to the stomach pathologies, very, very important, pyloric stenosis. What are the clinical features? This is generally in the firstborn male child, an olive-like lump felt in the epigastric region and the baby has non-bilious vomiting because it's a proximal obstruction. The age of presentation is not on day 1. It is like 1 month around, that is 4 weeks around. And what is the investigation of choice for pyloric stenosis? That is a question which is asked. The investigation of choice is ultrasound. Why ultrasound? Because we want to measure the hypertrophied muscle layer, right? It is hypertrophic pyloric stenosis. So it's a muscle layer which is hypertrophied, which can be measured on ultrasound. There is no radiation to the baby, so that's another advantage. So the length of the pylorus should be more than 16 mm. The thickness should be more than 14 mm to diagnose it as pyloric stenosis, hypertrophic pyloric stenosis. What acid-base abnormality do we get here? Because of the vomiting, the acid going out, it leads to metabolic alkalosis. And the immediate management is the correction of the fluid electrolyte imbalance. The surgery, the definitive treatment, the surgery is the Ramsted's surgery. Okay, that's the Ramsted's surgery. Now look at the ultrasound. What are we seeing here? This is the stenosed lumen. This is the thickened muscle. The thickness should be more than 4 mm. The length of the pylorus should be more than 16. 4 and 4 ka square 16. Here the channel length is 23. So this is elongated pylorus. The muscle is thickened. What do you see in barium meal? The distended stomach with the narrow pylorus. Anywhere narrowing is like a string. So this is called as string sign. String sign. This pylorus going into the duodenum, it looks like a mushroom. So the other sign we have is mushroom sign. Other sign in pyloric stenosis is the caterpillar sign. So like the caterpillars, we get this prominent peristaltic waves in the stomach that gives the caterpillar sign also in pyloric stenosis. Next one, so what bubble sign would you see in pyloric stenosis? It's only the stomach which is distended, so single bubble. So stomach obstructed, single bubble sign. बाद में duodenum, double bubble, फिर jejunum, triple bubble, ileum, multiple bubble. So basically duodenal obstruction will give double bubble sign. So duodenal atresia. What else related to duodenal atresia? We have annular pancreas. Annular pancreas surrounds the duodenum and obstructs the duodenum, and we have large band. Okay, large band. So that gives the double bubble sign. The triple bubble sign is jejunal atresia 1, 2, 3. And also remember the term apple peel appearance is jejunal atresia, and multiple bubbles is ileal atresia, which basically looks like small bowel obstruction, right? The distal small bowel obstruction. Now going to gastric ulcer, what sign do you see in benign and malignant gastric ulcer? So remember M for M, the meniscus sign is seen in malignant gastric ulcer. So here we have this meniscus appearance, and the line is rhyming with benign. So remember Hampton's line is benign gastric ulcer. So when you see the line, the lucent line like this, it is a Hampton's line, benign gastric ulcer. Do not confuse this with Hampton's hump. Hampton's hump is basically the infarct in the lung. It is pulmonary infarct which can occur secondary to pulmonary embolism, right? Pulmonary embolism. Now going to the next one, bowel obstruction. So what do we see with bowel obstruction? The small bowel obstruction. There are multiple air fluid levels which are in the step ladder pattern. They are not the balanced air fluid level. The air fluid level is not like this. The level is not at the same level. It is the step ladder pattern. So multiple air fluid levels in the step ladder pattern, more than 3 is abnormal. The central bowel loops. The fluid in the obstructed bowel sends the air in the volvulae conniventus. So you get the air locules in the volvulae conniventus, one behind the other, that gives the string of pearls sign. Okay, that gives the string of pearls sign. What should be the diameter to call it an obstructed bowel? We have the rule of 3, 6, 9. Small bowel more than 3 centimeters, large bowel more than 6 centimeters, and cecum is the most distensible more than 9 centimeters, then it is called as obstructed bowel. Now, how do you differentiate whether it's a large bowel obstruction versus small bowel obstruction, asked in one of the recent exam? So, large bowel has haustration, small bowel has the complete rings, volvulae conniventus. So, large bowel has haustrations which are incomplete projections, small bowel has complete rings. So look at this one that you see here. These are the incomplete projections. So this is a large bowel. These are the complete rings. So this is small bowel obstruction. Large bowel located more in the periphery. Small bowel located more in the center. That is how we differentiate. Intussusception. Now, how would the patient present in intussusception? Generally, it's a child, the weaning age group with the Peyer's patches hyperplasia, predisposing to intussusception, and the classical history we have is the red currant jelly stools. Red is the blood, currant is the mucus. So blood and mucus in the stools. The investigation of choice here is going to be ultrasound in a child because no radiation exposure. It can show the bowel within bowel appearance. So what do you see on ultrasound is one bowel inside another bowel, that is the target or the donut sign in the cross section. In the longitudinal view, it looks like the kidney. Okay, so it looks like the hilum and the kidney. So that is the pseudo kidney sign. Same thing we see in the CT also, the bowel within bowel appearance. CT is preferred in adults where ultrasound might limit the visualization of bowel loops. What are the signs on barium enema? Very, very important. So one is the claw sign and second is the coiled spring sign. So when the barium goes up, reaching till the point of the intersusception, then it forms a claw, or it can form the crescent also. So crescent sign or the claw sign. If there is some space in between the two bowel loops, the barium goes outlining the intersusceptum, and that gives the coiled spring sign. So remember, we have the claw sign and the coiled spring sign in intersusception. What is the management? Pneumatic reduction, that is air reduction. We put the air through the rectum and that pushes the bowel out, or we can do hydrostatic reduction also using saline. Hydrostatic reduction also can be done. So this is intersusception. Now going to sigmoid volvulus. Sigmoid volvulus means a twist. So there is acute pain in the abdomen. The predisposing factors are a patient with chronic constipation, with laxative abuse, psychiatric conditions. All these are predisposing factors. So when the sigmoid undergoes a twist, it is generally the anti-clockwise direction and it comes in the right upper quadrant overlapping the liver. And what it gives is this coffee bean sign. Okay, so we get this coffee bean sign, and which is also called as the omega sign or the bent inner tube sign. Other sign is this Freeman-Dahl sign, where you have these three lines basically which converge at a point which tells you the point of obstruction. So the three parallel lines converging together, that's the Freeman-Dahl sign. What do we have on barium enema? So the barium going up, it is blocked at the point of volvulus. So barium goes up, it is blocked at the point of volvulus. So that gives the bird of prey sign, right? Like a bird looking up, that is the bird of prey sign on barium enema. Okay. Now, how do you differentiate sigmoid volvulus from a cecal volvulus? So remember that sigmoid does not have hostrations. Cecum has the presence of hostrations. So in the sigmoid volvulus, the hostrations are absent. Here you see the presence of the hostrations, and that is why the cecal volvulus, it looks like a embryo. So we get the embryo sign. Cecal volvulus can be a single loop like this. Here we have two loops. Double loop is what we have. Cecal volvulus, the predisposing condition, it is common in pregnancy or post-pelvic surgery. Those are the predisposing factors. So that is sigmoid versus cecal volvulus. Now coming to ileocecal TB. Ileocecal TB, where TB everywhere causes fibrosis. Fibrosis means narrowing. So what do we get? Narrowing is the stricture, that is the string sign. So first is the string sign, where you see this narrowing in the terminal ileum. That's the most common site for GI TB. And it also involves the cecum. So cecum also gets fibrosed. So it is contracted and pulled up because of fibrosis. So we get the pulled up contracted cecum with the string sign. Another sign is this inverted umbrella sign, asked in one of the recent I9CT exams. So what is the inverted umbrella sign? So basically this ileocecal valve, it is thickened and it is gaping, it is widening. So the angle becomes obtuse. So the thickening and the widening, the gaping of the IC junction, this gives the inverted umbrella sign. Okay, that gives the inverted umbrella sign like this, the gaping and the widening. Now coming to colitis. Colitis, what happens because of colon inflammation is the hostrations get thickened. Edematous thickened hostration, they give the thumbprint sign. So this is what you see here in the barium, the thumbprint sign. Look at this X-ray abdomen. These are the hostrations which are thickened and edematous that give the thumbprint sign. Remember the thumbprint sign in the X-ray neck. Where do you see the thumb appearance in X-ray neck? It is epiglottitis. Okay, it is epiglottitis. Next one, what do you see in pseudomembranous colitis, which is caused by Clostridium difficile? Drug-induced like clindamycin drugs can cause this. So we have this accordion sign. So like the leaflets of the accordion, we get this appearance of the accordion in pseudomembranous colitis. Next, inflammatory bowel disease, that is ulcerative colitis and Crohn's disease. So, what do we have in ulcerative colitis? Remember, colitis has colon wala, the lead pipe colon and the toxic megacolon. What is a lead pipe colon? A colon which is smooth. That means there are no hostrations now. The hostrations are destroyed and it is rigid and small caliber. So look at this colon, which is appearing very smooth without the horstrations. This is the lead pipe colon. Ulcerative colitis has continuous involvement, retrograde without skip lesions. Here, this is the transverse colon, which is dilated. If it is more than 6 centimeters, then it is toxic megacolon. Do not do colonoscopy in toxic megacolon because it can lead to perforation, right? And remember the association of ulcerative colitis with primary sclerosing cholangitis. So whenever you have a male patient with diarrhea now presenting with obstructive jaundice, think of primary sclerosing cholangitis as well. What do we have in the Crohn's? Now Crohn's, remember the C and C. There is string sign of Cantor, I write it C. The comb sign, the cobblestone appearance, and also add one more C here. It has complete ulcers. Complete ulcers, through and through ulcers, which can lead to formation of fistula and abscess. So look at this one. This is the string sign of Cantor. Again, similar to TB, the terminal ileum is the most common site. We see the narrowing there. This is the cobblestone appearance, right? This is the comb sign where we see like the comb, the prominent vasa recta because of the inflammation. So this is the prominent vasa recta. And also the other feature is the anti-mesenteric border of the bowel shows saculations. So you would see the saculations in the anti-mesenteric border, and we have this ram's horn appearance of the stomach. So like this ram's horn, the stomach has this horn-like appearance, that is the ram's horn stomach. Horn ke saath rhyming is thorn. So also remember, we also see the rose thorn ulcers in Crohn's. The deep ulcers, those are the rose thorn ulcers in Crohn's. So these are the various features in Crohn's disease. Now coming to diverticulosis and diverticulitis. Diverticulosis on barium study shows this sawtooth appearance, like this sawtooth appearance because of the outpouchings. So what do we see here? These are the various diverticuli showing the sawtooth appearance. Investigation of choice, barium enema. But now if one of this diverticulum gets inflamed, it undergoes diverticulitis, and that will lead to pain, acute pain. So the patient presents generally with the acute pain in left lower quadrant. Why? Because the most common site is sigmoid, right? Now, so for acute diverticulitis, the investigation of choice would be CECT. We don't do barium in acute inflammatory conditions. So in CECT, what you might see is surrounding the diverticulum, there is this fat stranding area which tells you there is inflammation. It might show the perforation, the fluid going out. The classification used is Hinchey's classification, right? It is Hinchey's classification. So that is diverticulitis. Coming to Hirschsprung's disease, the clinical feature in Hirschsprung's is the patient not able to pass meconium. Hirschsprung's is basically aganglionic megacolon. So there are no ganglia because the ganglia are derived from neural crest cell. So there is failure of neural crest cell migration. So the aganglionic segment is contracted. Proximal to that, the colon is dilated. That is megacolon. So classically, what we see in Hirschsprung's is this zone of transition, the transition zone from the affected to the unaffected segment. And the rectosigmoid ratio in Hirschsprung's becomes less than 1. Normally, the ratio is more than 1. That means when you look at the rectum diameter versus the sigmoid diameter, the rectosigmoid ratio normally is more than 1. In Hirschsprung's, it becomes less than 1. So look at this one here. The rectum is 25. The sigmoid is 60. The sigmoid is more dilated. Rectosigmoid ratio is less than 1. Zone of transition or transition point is a very important clue for Hirschsprung's disease. It's a very important clue for Hirschsprung's disease. What do we have in acute appendicitis? So appendicitis will cause pain in the RIF and the McBurney's point tenderness. First the pain is periumbilical, then it goes to the RIF, McBurney's point tenderness. What is the investigation of choice? First investigation is ultrasound. But quite a few times because of the retrocecal location, the appendix might not be visualized on ultrasound. So the best investigation is CT scan. It shows the appendix irrespective of its location. So in ultrasound, we use this graded compression technique. We try to compress the appendix. If it is inflamed, it is filled with fluid, so it will not get compressed. So remember, the feature of inflamed appendix is it is non-compressible. Normal appendix gets compressed. Appendix is a tubular structure. It's a blind ending structure without a peristalsis. So that is the description of acute appendicitis. So look at this one. This is the appendix which is filled with fluid, distended. The diameter will be more than 6 millimeters. There is the surrounding fluid. The mesentery is echogenic. All the signs of inflammation. Sign in CT that we can see is this arrowhead sign because of the narrowing of the cecum as well. So we have the cecal bar or the arrowhead sign in CT. What score do we use for appendicitis? Remember, A for A, it is Alvarado score for appendicitis. So that was about the GIT part of the radiology. Now we will have a look at the hepatobiliary and the pancreas imaging. First, identifying the investigations here, very important. The first one here where we see the endoscope, the CBD and the pancreatic duct, that is endoscopic. So this is ERCP, where we see the CBD and the pancreatic duct, but there is no endoscope there, then that becomes MRCP. Where we have this T-tube that we are seeing here, you can see this tube coming from outside from the skin surface, and there's a T-tube. So this is a T-tube cholangiogram, and this one where we see the tube coming into the intrahepatic biliary radicle, that is PTC, that is percutaneous transhepatic cholangiogram, which is done in cases of when the main CBD is obstructed. We cannot go via the main CBD, so we come via the peripheral radicle. T-tube is done in the post-operative period. Now, what is the advantage of ERCP over MRCP? It is therapeutic as well because we are putting a catheter into the duct, so it is therapeutic as well. We can take a biopsy, we can remove the stone, but it has radiation exposure and it is invasive. MRCP on the other hand is MRI, so there is no radiation, there is no contrast, it can be done without contrast. What sequence do we use? A T2 weighted sequence because we want the water white. So it's a T2 weighted MRI and it is non-invasive. That is the advantage. So MRCP is generally the investigation of choice for biliary pathologies. ERCP is generally the gold standard because it is invasive. Now coming to the liver. Liver lesions, first the cystic lesions. Simple cyst versus abscess versus the Carolese. Now simple cysts are basically the ones which are water containing, so they will not enhance, and they have thin walls. So simple cysts are water containing, non-enhancing. Now if a cystic lesion has thick wall, so like you see here, there's a thick wall with the surrounding hypodense edema, then we think of abscess. So thick wall with surrounding edema is abscess. On ultrasound in the abscess, we would see the echoes and debris within because of the pus. Now the abscess could be the amoebic liver abscess or it could be pyogenic abscess. In amoebic liver abscess, we have the history of amoebiasis, the dysentery, amoebic dysentery as well. Pyogenic is generally a multiple abscess, while amoebic abscess is generally a solitary abscess with anchovy sauce appearance, right? The anchovy sauce appearance on cross examination. When you have the cystic lesions in the liver with the white central dot, that is the Carolese disease. Okay, that is Carolese. So remember, central dot sign C for C is seen in Carolese disease, which is type 5 choledochal cyst. Next one, another cystic lesion is the hydatid cyst, which is caused by echinococcus. So hydatid cyst has that mother cyst with multiple daughter cysts within. So that gives the spoke wheel appearance, the multiple daughter cysts, the spoke wheel appearance. It can also give this honeycomb appearance where you have the mother cyst with multiple daughter cysts, and the rupture of the membranes can give this floating water lily sign. So we can see this water lily sign which we see on chest x-ray as well. So that is water lily sign. So this hydatid cyst later on in the last stage it calcifies. In which organ the hydatid cyst does not calcify? It does not calcify in the lung because of the continuous movement of the lung. There is no calcium deposit. Coming to the solid lesions, hemangioma. Very commonly seen lesion. Classical appearance is on the triple phase CT, which is done for liver lesions. You would see that hemangioma shows this peripheral nodular enhancement in the arterial phase. Then this enhancement goes on increasing centrally with centripetal filling. So that is what we see. What nuclear scan helps for liver hemangioma? It's the technetium 99 RBC scan. Remember, heme matlab blood matlab RBC. So we do RBC scan. What are the classical features of HCC? The hepatocellular carcinoma. Because the HCC is supplied by hepatic artery and not the portal vein, it shows early arterial enhancement. So in the early arterial phase, they would show the enhancement. They will show the washout. When the rest of the liver starts enhancing, they show the washout. So then they appear hypodense, and then they can give in the delayed phase a pseudo capsule appearance. And remember, we use LIRADS. LIRADS is for liver lesions. The probability of the lesion being HCC in the background of cirrhosis, hepatitis B, that is LIRADS. Now coming to gallbladder. Generally, the investigation of choice for gallbladder is ultrasound because it's a superficial organ, fluid containing organ. Right. So even for gallstones, the investigation of choice is ultrasound. We identify gallstones by this posterior acoustic shadowing. The black area behind the stone, posterior acoustic shadowing. The stone itself is echogenic. It is hyperechoic, but behind that is the shadow. On a radiograph, we might see this stone containing the triradiate air like the Mercedes-Benz sign. Okay, that is called as Mercedes-Benz sign. Now, these stones can predispose to cholecystitis. So, a patient with acute cholecystitis has right hypochondriac pain, vomiting, and Murphy sign is positive. The investigation of choice is ultrasound, but the gold standard investigation is HIDA scan. The gold standard investigation is HIDA. Now, what are the findings in acute cholecystitis? Now, remember that any organ which is acutely inflamed is distended, fluid containing, there is surrounding fluid as well. That is what we see, a distended gallbladder with thick wall because of the inflammation surrounding fluid. Thick wall means the wall is more than 3 millimeters. And there may be or they may not be stone. It might be calculus or acalculous cholecystitis. So that's why HIDA is the best because it helps us evaluate both the calculus and the acalculous cholecystitis. In HIDA, we see the hot rim sign or the hepatic rim sign. The surrounding liver shows the inflammation. The gallbladder itself does not show the HIDA uptake because it is obstructed. So non-visualization of gallbladder with the hot rim sign is what we see in HIDA. Next one. Now, classically what I am seeing here is this black air on CT. Black on CT is air. And this is the black air on X-ray. This is emphysematous cholecystitis, which is common in diabetic patients, can predispose to gangrene of the gallbladder. Adenomyomatosis shows comet tail sign because of the cholesterol deposits. Remember, comet tail COCO is seen with cholesterosis of gallbladder, which on gross examination shows strawberry gallbladder. So look at this comet tail sign coming from the gallbladder wall, the gallbladder showing this comet tail sign. Where do we see the comet tail sign on CT? It is seen in asbestosis with the round atelectasis pulling the vessels towards itself. That shows the comet tail sign on CT. Now coming to bile duct. Now bile duct this is the ERCP and you are seeing this filling defects. This is MRCP with the filling defect suggestive of choledocholithiasis. Right? It is choledocholithiasis, that is stone in the bile duct. Now, when you have this beaded appearance of the bile duct, you can see the beaded appearance extrahepatic, the intrahepatic radicals also showing the beaded appearance. That is seen with primary sclerosing cholangitis because of the fibrosis and strictures. We said that it's associated with ulcerative colitis. On histopath, it will show the onion peel fibrosis. What is that condition where in a neonate with obstructive jaundice on ultrasound you get the triangular cord sign? So at the porta, in front of the portal vein, you see this triangular cord sign which represents a fibrosed area of the bile duct. So that is biliary atresia. And we rule out biliary atresia by what investigation? By HIDA. So if you see the HIDA coming into the bile duct into the duodenum, we know that the biliary tree, the biliary tract is patent. So HIDA helps us rule out the biliary atresia. Where do you see the double barrel sign? Now double barrel sign is the appearance of this portal vein and the dilated CBD. The CBD becomes as dilated as the portal vein. So these two, they give the double barrel sign. which is seen with any cause of CBD obstruction, that gives the double barrel sign. Now coming to the pancreatic pathologies, pancreas, acute pancreatitis, a patient presenting with abdominal pain radiating to the back, serum lipase, amylase are increased, and they tell you that on CT there is bulky pancreas. Again, because of acute inflammation, the pancreas will be bulky. Chronic pancreatitis, the pancreas will be atrophic. Fibrosis, atrophic, right? So what do you see is bulky pancreas with the surrounding fluid is what you would see. The surrounding fluid is what do you see in acute pancreatitis. This fluid can now, after 4 weeks, it can form a wall and it can form this pseudocyst, as many times in the previous exam. So this is a pseudocyst of the pancreas, the water density lesion, homogeneous with a thin wall. This is after 4 weeks in non-necrotizing pancreatitis. What do we have in X-ray in acute pancreatitis? One is the colon cutoff sign, the sentinel loop sign, and the gasless abdomen. Colon cutoff sign is this air in the transverse colon suddenly getting cut off because of the ileus, which is induced by the inflamed pancreas in the surrounding area. So that is the colon cutoff sign. The air gets cut off. The rest of the bowel has gone into like functional obstruction. Sentinel loop sign is adjacent to the pancreas. The sentinel bowel loop has become dilated. And the gasless abdomen is also what we see because of recurrent vomiting. Chronic pancreatitis, remember C for C, it has calcification and chain of lakes appearance. So when you see the calcification in the pancreas, think of chronic pancreatitis. For chronic pancreatitis, MRCP, ERCP is a better investigation. Why? Because it helps us look at the dilated duct. The duct is dilated because of the atrophic pancreas, more than 3 millimeter dilatation, and you would see the chain of lakes appearance. The dilated duct with the multiple side ducts also dilated. This main duct might show the beaded appearance also because of the multiple strictures. Now, what do you see in periampullary carcinoma? So, this is the duodenum. We have the CBD, the pancreatic duct, the ampulla of Vater, where surrounding that we get the tumor. So, periampullary carcinoma is in the duodenum, in the pancreatic head, the terminal CBD. So, any periampullary carcinoma, what will it cause? It will cause the widening of the C loop because it wants space. So, there is widening of the C loop of the duodenum. And what do we have is the reverse figure of 3 sign. The periampullary carcinoma causes the pulling of the duodenal wall that gives the reverse figure of 3 sign. It compresses on the stomach that gives the antral pad sign. It dilates, obstructs both the CBD and the pancreatic duct. So, it gives the double duct sign. So, double duct sign is the dilated CBD and the pancreatic duct also in the periampullary carcinoma. So, these are the various signs in periampullary carcinoma. So, that was about the hepatobiliary and the pancreatic radiology. So, this completes GIT, hepatobiliary and pancreatic radiology, which is very, very important. Just to add on one more point related to the bile duct leak. So, remember that bile duct leak in post-cholecystectomy patient, a patient with pain, abdomen, fever. First investigation is ultrasound to look for the fluid. If the fluid is present with the symptoms, we presume to be bile duct leak and we can go ahead with pigtail drainage. But if you want to confirm that this is bile leak itself, then you can do the HIDA scan to confirm, basically because HIDA is the most sensitive investigation. But the disadvantage with HIDA, it will not tell you the site of the leak. To localize the site, we need to do ERCP or MRCP. So, understand the role of the various investigations in a case of bile leak, which is frequently asked in INICET exam. So, now we are going to learn about urinary tract imaging. That is the renal part, the kidneys, the ureters, the bladder, and also the adrenal. So, first let us have a look at the various investigations and the modalities. So, how do you identify the IVP, RGP, MCU and the RGU? Now, all these are the contrast studies, the contrast X-rays. So, all of them have radiation exposure. All of them use iodinated contrast because they are X-ray based modalities. Now, when I say pyelogram, you would see the pelvic calyceal system of the kidney. So, when you see the kidney, then it is a pyelogram. right? And you do not see the urethra in that case. So kidney, ureter, bladder, a contrast X-ray of that is the IVP, contrast given IV. So it gets excreted into the kidneys and then it goes into the ureter and the bladder. So urethra is not seen in IVP. So next that we have is RGP, retrograde. So in retrograde, you would see some cannula or catheter sort of thing at the site of the ureteric orifice. And then you would see the contrast. So generally it's one kidney at a time. MCU is micturating cystourethrogram or voiding cystourethrogram. So here what we do is we fill the bladder with contrast, distend the bladder with contrast by putting the Foley's, and then we ask the patient to micturate on table and we take images. So here the bladder would be distended, the patient is micturating, so the contrast also would be seen in the urethra. So that is the cystourethrogram. RGU or ASU, that is retrograde urethrogram or ascending urethrogram. The cannulation is at the external urethral meatus and then the contrast is pushed into the urethra, right? So here the bladder is not completely distended with contrast. So where are these modalities used? IVP is a very sensitive investigation for renal TB. The earliest finding that we have is moth-eaten calyx. Now, IVP has been replaced by CT-IVU in the practice. MCU or VCUG, remember, is the investigation of choice for VU. Remember the VU, it is the investigation of choice for VUR, vesico-ureteric reflux, and VU containing a pathology that is posterior urethral valve. It contains the U and the V both. And remember that in VUR, if the question is to demonstrate the reflux, MCU is the investigation. To look for the scar in the kidney, the nuclear scan DM assay is done for the scar in the kidney. RGU ASU is for the urethral stricture, the urethral rupture. It will show the contrast extravasation. RGU is better for anterior urethra. MCU is better for the posterior urethra, which is close to the bladder. So for posterior urethra, it is MCU. Okay, that is what we need to remember. Now, next, what are these investigations here? This is the white bones and we see the CT-IVU here. We can make a colorful 3D volume rendered image from it. And this is MR urogram where you don't see the white bones, right? Urolithiasis, that is the stone in the urinary tract. The investigation of choice is non-contrast CT because these stones are generally calcified. So for calcification, it's NCCT. But where do you use DECT, dual energy CT? That is used specially for uric acid stone characterization. Now, urolithiasis, you have the stone in the kidney. This is like a staghorn calculus following the pelvic-calyceal system. If you see the stone in the paravertebral position, that is where the ureter goes. So that is ureteric calculus. And if there's a stone in the bladder, in the pelvis, then it's a bladder calculus. Now, urolithiasis has pain. Where is the pain? It is the loin pain, right? The patient complains of pain in the loin and going to the groin. So it is loin to groin pain. Along with that, there can be hematuria. So pain along with hematuria is what is the history that we have in renal stones. Now, renal calculus, we said the investigation of choice is non-contrast CT to look at the stones. So this is the kidney showing the white calcified stone. What muscle is this? This is the psoas muscle related posterior to the kidney, adjacent to the vertebra. That is where we see the TB abscess also. From the spine, it can go to psoas muscle. This is an ultrasound showing the stone in the kidney. Why do I call it stone? Because there is posterior acoustic shadowing. Is it obstructing? Yes. Why? Because I can see this black fluid here. There is hydronephrosis which is present here. So this is the kidney with the stone and the hydronephrosis. What is this? This is gross hydronephrosis. We just see the paper-thin parenchyma which is enhancing. So this is like a rim of the parenchyma enhancing. This is called as rim sign which is seen in hydronephrosis. Rim sign, hydronephrosis. Now, staghorn calculus. Staghorn calculus follows the shape of the pelvic calyceal system, also called as true white stone made up of triple phosphate. Remember the mnemonic for true white? True white is staghorn. It is urease positive organisms like Proteus which predispose, and it is white clothes. Where do we wear the white clothes? In a funeral. That is coffin lid. So remember, it has coffin lid appearance in the urine. What are the DDs of this calcification in the kidney? One, it could be the staghorn calculus. Second, when you have this bilateral calcification in the kidney, in between which you have this lucent areas also, this is medullary nephrocalcinosis. There are multiple causes, hypercalcemia, sarcoidosis, medullary sponge kidney. And this one where you see that it's a unilateral kidney, which is showing this calcification with the lobulated appearance, parenchymal calcification. That is the putty kidney, which is seen in late stages of TB. The kidney becomes non-functional. So this is generally unilateral. This is bilateral. Now, how do you differentiate whether the image is showing staghorn or PUJ or VUR? Now, staghorn will be a plain X-ray. The calcification is seen on a plain X-ray. For PUJ obstruction, to demonstrate the obstruction at the pelviureteric junction, we need to do a contrast scan and show that the contrast is not going into the ureter. So that would be done on IVP. So this would be an IVP image. So you would see the other kidney as well, the ureter, the bladder containing the contrast. And you are seeing that one kidney here is dilated, hydronephrosis, without a hydroureter because the contrast is not going into the ureter. In VUR, what is the investigation? It is MCU. It's not IVP which demonstrates the VUR. So MCU, where you would see the cystourethrogram. So the bladder and the urethra. But in the MCU, if you see the contrast going into the ureter and the kidney, that means when the bladder is contracting, the contrast is going up. That means there is reflux happening. So VUR is identified by the visualization of kidney and the ureter on MCU. So PUJ would be IVP, no ureter visualization. MCU, VUR would be MCU with the ureter visualization. Right? Now, how do you differentiate whether it's a bladder cal or a calcified fibroid in the X-ray pelvis? So a bladder calculus will be dense calcification or lamellated calcification. Fibroid will show this popcorn calcification, a previous FMG exam question. So there the history would be a postmenopausal female. Now in postmenopausal, the fibroid undergoes involution, degeneration, calcific degeneration. So that is popcorn calcification. The stippled or the popcorn calcification is what we see. Pyelonephritis. Now remember the history in pyelonephritis, inflammation, there's going to be fever. There's going to be dysuria, there can be hematuria. So fever and pain, the loin pain history is important. Fever is important there. Now in pyelonephritis, acute pyelonephritis, again the kidney will be enlarged. Chronic pyelonephritis, the kidney would be shrunken. So enlarged kidney with this striated appearance, that is what we see in acute pyelonephritis. Xanthogranulomatous pyelonephritis has this beer paw sign, where you get the contracted pelvis with the stone within and the dilated chelicus. So you have the contracted pelvis with the dilated chelicus, beer paw sign. And when you have the air in the kidney, that is emphysematous pyelonephritis, like emphysematous cholecystitis. Okay, so these are various pyelonephritis. TB of the urinary tract, kidney, ureter, bladder. So in the kidney, in the last stages, we said that it gives rise to this putty kidney, the calcified kidney, very frequently asked. The history here is sterile pyuria. So there is pus, there is pyuria, but there are no organisms which are seen or grown because it is acid-fast bacillus, difficult to grow. So this is putty kidney. Autonephrectomy, this is non-functioning. Earliest finding, moth-eaten calyx. Ureter getting affected, multiple strictures, that gives the beaded or the corkscrew appearance. So there are multiple strictures. On a cystoscopy, we see the golf hole appearance of the ureteric orifice, the kinking of the ureteric orifice. Bladder is contracted because of the fibrosis. It's a small capacity bladder, which is called as thimble bladder. So remember thimble bladder, TB. Thimble bladder is seen in TB. So these are the various appearances here. Now coming to the important IVP appearances. First one that we see here. This is the ureter showing this dilatation like the cobra head or the adder head appearance, which is seen with ureterocele, the dilatation at the insertion into the bladder. Where do you see this drooping lily appearance? Drooping lily, remember D4D is seen in duplication or the duplex moiety, where what happens is the upper moiety, which is obstructed and enlarged, it compresses on the lower moiety. So the lower moiety gets drooped. So we get the drooping lily is actually the lower moiety which is functioning and it is compressed by the upper moiety. So in this duplication, what rule do we have? We have the Wiegert-Mayer rule. What does the Wiegert-Mayer rule say? The upper moiety inserts lower down and the lower moiety inserts up. Basically, this has orthotopic insertion. The lower one, the upper one has ectopic insertion, inferomedial to the lower moiety, right? Which is predisposed to ureterocele and which is predisposed to VUR. So remember that ureterocele U for upper moiety, lower moiety, lower is the VUR. Okay, lower is the VUR, right? Now going to the next one that we have here. This one is the paintbrush appearance, right? The multiple dilated collecting ducts giving the paintbrush appearance or the bouquet of flowers appearance, which is seen with medullary sponge kidney. The collecting ducts in the medulla dilated, they give this paintbrush or this can be the bouquet of flowers appearance, medullary sponge kidney. Spider leg appearance, what are we seeing here? Look at the calyces, how they are splayed, they are separated because of the cyst in between. So in between the calyces, we have the multiple cysts causing the spider leg appearance, autosomal dominant polycystic kidney disease, right? Because of the multiple cysts, the calyces get spread. Then we have the maiden waist deformity of the ureters. So maiden waist is like this. Okay, the figure coming like this. ऐसे आ रहा है and then there is this patli kamar like, that is the medial deviation of the ureters, and this medial deviation of the ureters is because of the fibrosis. So the fibrosis pulls the ureters medially. So this is seen in retroperitoneal fibrosis. The primary one is called as Ormond's disease. It can be secondary also, like in IgG4 disease, drug causing retroperitoneal fibrosis. Methisergide is an important drug side effect to be remembered. Now, where do you see the flower vase appearance? So you have the kidney, which is medially located, one kidney coming towards the other kidney. So basically that is horseshoe kidney. Horseshoe kidney, and this is called as handshake appearance or the joining hands appearance. Very, very frequently asked. So horseshoe kidney is where the kidney is united at one pole and the kidney is not able to go up because it is obstructed by inferior mesenteric artery. The isthmus is generally located at L3 level, at a comparatively lower level. So this is the horseshoe kidney, and it is showing the flower vase or joining hands or handshake appearance. Remember, it is associated with Turner's. Okay, it is associated with Turner's. Next, what we have here is this retrocaval ureter. So this is the IVC, this is the aorta, and behind the IVC you see this contrast containing ureter. So embryologically defect, ureter is retrocaval. So the IVC compresses on the ureter. So the proximal part of the ureter and the kidney is dilated. So proximal hydronephrosis, hydroureter is what we have. So look at the ureter here, which is going overlapping the vertebra, telling that it is retrocaval. So the retrocaval ureter shows this proximal hydroureter. This is called as fishhook ureter or the J-shape ureter. Where do you see the distal fishhook appearance of the ureter? This is the distal ureter showing this fishhook appearance. This is because of the enlarged prostate. It is seen in BPH, prostatic enlargement, causing the ureter elevation. This is the proximal fishhook. This is the distal fishhook. Proximal is the retrocaval ureter. Distal is the BPH. Now, renal papillary necrosis, multiple causes. So what are the various signs in renal papillary necrosis? So the papilla, if this part gets necrosed, so the contrast goes in that part, calyx is communicating. So the first sign that we see is this ball on T appearance. So look at the contrast of the calyx, contrast in the papilla. Ball on T sign. Next is the callicial fornix growing around the necrosed papilla like the lobster claw. So the next is the lobster claw appearance. Now this claw becomes a complete ring. So you see this complete ring around the necrosed papilla, that is the signet ring sign. And then we have the next one. Now it gets, the normal calyx is concave. Now the calyx gets convex, that is called as clubbing of the calyx. So all these signs can be seen in TB also, because TB is one of the causes of renal papillary necrosis. Okay. Now going on to the next one, the bladder appearances. So what do we have in bladder appearances? First one here is the Christmas tree appearance of the bladder, right? So like the Christmas tree, the bladder is elongated, right? It is elongated. It is not round now, and it has these multiple diverticuli. So this is called as Christmas tree, which is seen with neurogenic bladder. Christmas tree appearance is seen with neurogenic bladder because the tone of the bladder is affected, so it loses the shape. Pressure is high, so it forms the diverticuli. So Christmas tree, fir tree or pine tree bladder. Next that we have is, look at this bladder. It is elongated, but it is smooth walled. There are no diverticuli. So from round, it has become like this. So a round bladder, when compressed from outside, it will become elongated, right? So any cause of extrinsic compression will lead to this appearance, and this is called as pear-shaped or a teardrop bladder, right? That is how the shape of the teardrop is. So what are the causes here? Pelvic causes, pelvic space occupying lesions, like we have pelvic lipomatosis, pelvic abscess, pelvic hematoma, multiple causes of this appearance of the bladder. Now what are we seeing here? This is where we have the bladder and the dilated posterior urethra. That is keyhole appearance of the bladder, which is because of the valve which is located here. That is the posterior urethral valve. So remember, the keyhole bladder is seen with posterior urethral valve. What is the investigation of choice? VCUG, MCU, not the retrograde urethrogram. This image is showing the fetal skull calcification. The bladder wall is calcified, and this is seen with schistosomiasis. Which schistosoma in the bladder? Hematobium. Okay, it is schistosoma hematobium. The U and the B, that is urinary bladder wala. It can cause bladder cancer. What investigation is this one here? We see the bladder, we see the urethra, and we see the ureter also. So this is the MCU, and in the MCU, we are seeing the contrast going into the ureter. So this patient has both the posterior urethral valve and the VUR also. There is this dilatation of the posterior urethra, the keyhole appearance of the bladder. Now coming to the urethral pathologies. For anterior urethra, RGU. For posterior urethra, MCU. So what are we seeing here? This is the RGU image. You see the syringe filled with contrast. Look at the narrowing in the distal most urethra. That is the penile urethra. There is stricture there. So what do we have? Prostatic urethra, membranous urethra, the bulbar urethra, and the penile urethra. Okay. The narrowest part is the membranous urethra. This is urethral rupture. You can see the contrast in the urethra has gone out. So this is urethral rupture. So what investigation we do in urethral rupture is RGU. It is RGU that we do. So when there is pelvic fracture, the urethra adjacent to that is the membranous urethra gets injured. So in history of pelvic fracture, there is going to be membranous urethra rupture. Now that was urethral rupture. What do you see in bladder rupture? Now urinary bladder rupture could be extraperitoneal or intraperitoneal. More common extraperitoneal. So extraperitoneal, you will see the contrast just accumulating around the bladder localized there. That gives the molar tooth sign. So remember, the molar tooth sign is the extraperitoneal. Intraperitoneal means it will go in the paracolic gutters in between the bowel loops. So that would be intraperitoneal. Okay. So intraperitoneal we see when the bladder is distended and then there is abdominal injury. So that the dome of the bladder is affected in that case. Next we have now coming to the renal mass. Now renal mass, if it does not show any enhancement, think of a renal cyst. What classification do we use for renal cyst on CT scan? That is Bosniak classification, right? We have Bosniak classification. Bosniak 1 is a simple cyst, non-enhancing, no septa. Bosniak 4 is the one which has maximum chance of malignancy. It is enhancing, it has solid components, right? If you see the presence of fat in a renal lesion, fat is lipo. So think of angiomyolipoma. It's a fat containing. How do you identify the fat in the lesion? By comparing it with the subcutaneous fat, the mesenteric fat. It appears dirty black because it has negative HU value. So angiomyolipoma will have fat containing areas. If you have bilateral angiomyolipomas, then it would be tuberous sclerosis. Angiomyolipoma will enhance because it has the solid component, the angio component as well. If there is enhancement but there is no fat, then you think of renal cell carcinoma or other tumor. So like this, in this case, you are seeing this enhancing lesion in the kidney. This is RCC. Remember, generally it's a clear cell cancer which is hyper enhancing. Okay. And clear cell cancer is associated with von Hippel-Lindau syndrome. What is the investigation to look for IVC extension of the tumor, the RCC? In that case, it is MRI. For the intravascular extension, MRI is a better investigation. Otherwise, for RCC, we do CECT. How do you differentiate a Wilms from neuroblastoma? So, a child with an abdominal mass, neuroblastoma could be less than 1 year as well. Wilms is like around 5 years. And the radiological features, Wilms arises from the kidney. Neuroblastoma is suprarenal. So, this you would see is actually arising from the kidney. Neuroblastoma is separate from the kidney. Neuroblastoma crosses the midline. It has calcification. It encases the vessel. The aorta is encased. While Wilms has displacement of the vessel, you can see the aorta has gone to the right side. So there is displacement of the vessel. It does not cross the midline. Those are the differentiating features there. Neuroblastoma shows bony metastasis. Right? It can show the sutural diastasis. All those features can be seen. Now, coming to the cystic lesions in the kidney, the polycystic kidney disease. In the adult, AD, autosomal dominant AD in the adult, which has big cyst bilaterally. So, you would see both the kidneys are enlarged with multiple cysts. So, bilateral enlarged kidney with multiple cysts. Patient coming with hypertension, renal failure. This is a CT scan because the bones are white. This is MRI because the bones are black. Previous FMG question, identify this is CT or MR and what is it showing. What do you see in a nephrogram in autosomal dominant polycystic kidney disease? The cyst will not take up the contrast. They will show the filling defects like a Swiss cheese. So Swiss cheese has those multiple holes. So Swiss cheese appearance. In the later phase of IVP, we have already seen it will show this spider leg appearance because of the splaying of the calyces. Okay. What is the difference between multicystic dysplastic kidney and polycystic kidney disease? Now, multicystic dysplastic kidney is usually unilateral and autosomal dominant is bilateral. This can be seen antenatal as well. So, on antenatal ultrasound or in a neonate, if you see a kidney which is completely replaced by the cyst, there is no functional parenchyma that we can see, then we should think of multicystic dysplastic kidney. It is generally unilateral. Now coming to renal artery stenosis, which could be because of atherosclerosis. It could be fibromuscular dysplasia as well. So atherosclerosis involves the ostium from where the renal artery is originating. Now what investigation is this? This is MR angio because I don't see the white bones. And in this MR angio, look at this narrowing. This is renal artery stenosis. So renal artery stenosis, the patient presents with hypertension without family history, right? The first investigation is Doppler, right? And what will you see on Doppler? On Doppler, the flow in the renal artery, the intraparenchymal renal vessels, they will show the Parvus-Tardus waveform. That means it is slow rising and less rising. The velocity intrarenal is decreased and it's a slow rising. The acceleration time is increased. So Parvus-Tardus waveform is what we see in the intrarenal arteries. What do you see in fibromuscular dysplasia? It's generally more common in female. The patient presents with hypertension and again in this MR angio, you are seeing this beaded appearance of the renal artery because of the multiple strictures, fibromuscular dysplasia. It gives this beaded or string of pearls appearance of the renal artery, FMD. Okay. Now going to the adrenal lesions, the most important being adrenal adenoma and pheochromocytoma. Now adrenal adenoma is the most common incidentaloma, that is incidentally identified lesion in the adrenal. Majority of them are fat containing, so their HU value will be less because fat has negative HU, less HU. So if you see an adrenal lesion with area, the HU value less than 10, straight away it becomes adrenal adenoma on non-contrast CT as well. But suppose if you don't see that and you want to confirm it's adrenal adenoma, then we do a contrast enhanced CT with a delayed scan taken after 15 minutes to look for the washout. And in adrenal adenoma, a previously asked question, it shows the early wash-in and the early washout of the contrast. So remember, it shows early wash-in, early washout of the contrast. Pheochromocytoma, on the other hand, on MRI, T2 weighted MRI, it would show this light bulb appearance. It will appear bright, light bulb appearance on T2 weighted MRI. What nuclear scan do we do for pheochromocytoma, especially if it's extra-adrenal? MIBG scan or even DOPA PET is what we can do for extra-adrenal pheochromocytoma. And remember that we should always include the adrenals in the CT scan of a patient of lung cancer, because in lung cancer, adrenal metastases are very common. So if you get a question, a lung cancer patient with adrenal lesion HU value 5, it is not metastasis, it is adenoma, because HU less than 10 makes it a adrenal adenoma, right? So yes, that was about the urinary tract imaging. Everything of that is important, and I hope it is now easy. Thank you so much.